into this, and I'd like for it to get a bigger audience than what we have here tonight. And so for those of you that don't know Christina, and I'm awful because I don't know anybody's formal titles or anything, but I do know what Christina does, because we both attend a what they call the crisis action team every month, which is something that's kind of grew out of our MHSA planning from years ago, where the Department of Behavioral Wellness decided to convene this convene a crisis action team to kind of deal with the issues on crisis services that crop up, around the county from time to time. And it's really, I don't know how Christina feels, but I think it's been one of the things that's been a real success, because what happens is we get all the politics and the managers and vice presidents and directors and everything out of it, and we get together the people that are actually on the street that get things done. And when we leave, when we have problems, and when we put them on the table, and we have people like Christine and John Winkler in the past, who was the head of crisis services, and now it's Jeff Shannon, and folks like that, as well as people from law enforcement and the other provider groups. A lot of times we can find solutions to problems and get things done that we can't get done on a much higher, grander level. And that's one of the things I like about it. It's sort of a skunk works, and Christina has been, just a loyal attendee at that and participant in that meeting. And every month she gives us the statistics, of how many crisis calls were there for kids, what were the outcomes and all that. And it's really, for somebody, that where a lot of us at NAMI are focused more on adult services or have been in the past, it's really impressive to see how much is going on in all the services that are there for kids. And so anyway, so Christina's job, she works for the Casa Pacifica, and Casa Pacifica has the contract to provide crisis services for children and adults throughout Santa Barbara County. So just like the mobile crisis team would be called for adults, you call Christina's group, which in her group is an acronym, of course, like everything else, is SAFTY, and you'll have to explain, what the SAFTY means. I should know, but I don't. But anyway, so it's Christina's team that actually is responsible for responding to and resolving crisis situations that come up with kids and adolescents in our county. And Casa Pacifica has done a great job with that over the years. So you can correct all the things that I said that were wrong, Christina. And while we were talking, we had a few more people join, so that's good too. So hopefully we'll have a few more. So, and take all the time you need.
Thank you for the introduction. I'm so excited to be here, and I am so excited and honored to be asked to do a presentation with NAMI. You guys are amazing. I'm so glad to see it moving in the direction of North County too, and that the service, your program is with the Zoom and stuff, more people can attend throughout the county to get that support, which is really awesome. I'm gonna share my screen. Well, first I'll say who I am. I'm Christina Lombard. I'm a licensed marriage family therapist. I work for Casa Pacifica Safety Program, and I've been with the Safety 5 years in a few weeks. So sounds like a lifetime. But we have a joke that crisis is like dog years. 7 years is really for each year you work in crisis. That's what it really is. But I like crisis. It's different. But then I'll share my slides, and it takes me a sec here because I gotta put it on the little, hold on. I want to be able to put it on the actual, and then I still like to see you guys. So it ends up sometimes not going on the correct screen. So give me a sec.
I think you should have three screens on the side, and then they can be scrolled up and down. But
yeah, I think I need to do it this way. Stop share. Sorry, this has confused me a few times doing this recently.
While she's doing that, let me just make a comment too. If you have questions during the presentation, I don't know how you want, if you want to take them right away or wait till the end, but put them in the chat box, and we'll handle the questions at the end if that's all right, or if we see something that looks like it's about something that you're talking about, we'll go ahead and take it then. Okay.
Okay, I may have to just do it this way. It's not working, right? So I'll just share my screen. Sorry, guys. This is still, see, George, you're not the only one that has problems with this. Can you guys see the slides?
Yeah.
Okay, you can see my notes. It's not a big deal. There's the first slide, so we'll start. That's just the entrance. I can still see you guys, which is great. I like to see you guys. I put both the numbers on here, like George said. The access line is the 24/7 line for the county, for Santa Barbara County, for crisis, and they're all ages when we're not on. And then, like George said, we're contracted with behavioral wellness. We have been with Santa Barbara County and Be Well since 2005. This program started. It's evolved a lot and changed a lot as the county has changed mental health services for youth. And like George said, it's funded through the MHSA dollars and Medi-Cal dollars. So when we first started, we didn't have the privilege of writing a hold. We were 24/7 until 2 years ago. And then it kind of evolved. And then we used to have to call CARES to write the holds if we were out on a crisis. And then they gave us the privilege because as we grew, we started having more and more contact with youth. So they couldn't keep up that volume to support 2 teams. Plus, if you're paying 2 teams, that doesn't fiscally seem sound. But then we weren't going into the ERs, but now we are. So we've evolved and changed. But we are 8 a.m. to 8 p.m., 7 days a week, at all holidays. And we cover the entire Santa Barbara County. So Carpinteria, Napomo, New Cuyama, all the way to Guadalupe. And then my contract, I like to be really transparent about like what we're dealing with as a contract. It's 8.5 specialists for 7 days a week. Once we became not 24 hours anymore, and the county and our director, they collaborated about that. They gave me an extra staff and a half, which I think has been great. And I think it's really helped with retention, staff morale, less burnout, things like that. The after hours, when we have a voicemail, and families do leave voice messages, and we just say to call 911 when we give them the access line. Also, it's used for the after hours crisis line team. If they write a hold or have contact with the youth, they will leave us voice messages and we follow up in the morning. So who do we serve? Like I said, all the way up to the 21st birthday. At the 21st birthday, it goes to the adult team. So we have that overlapping 18 to 20 age window that is adults. So that opens up a little bit more resources sometimes with the adults versus our kids. And like I said, Medi-Cal, MHSA fund, and we serve the population. We do risk assessments for suicide attempts, suicidal ideation, self-injurious behaviors, homicide ideation, homicidal thoughts, aggression, severe anxiety, and psychosis. We dispatch for mental health reasons. And this is kind of continued. I like to share who calls us. Most of our calls come from law enforcement, other providers in the community. Schools is a huge utilizer of our service, although with the pandemic, I'll go into that a little bit later, how that shifted when schools kind of just shut down last year when the pandemic hit, and we've seen a shift. I'm watching the data and monitoring it and how that changed for us. Emergency rooms, juvenile hall, county mental health, even therapists in the community will dispatch to therapists in the community. And we really dispatch to all sorts of, we meet the families where they're at. We've gone to parking lots. We've gone to the beach, the cliffs. It could be on a freeway, doctor's offices. We will meet the families where they're at. And then our goal, so we're super transparent of what our goal, of course, our goal is crisis stabilization and intervention, providing that support for families when they're in their child or youth is having a mental health crisis, and doing that risk assessment to determine what is the best clinical decision for this family, for the client. But it really is also to reduce the number of holds, psychiatric holds. So you guys have probably heard the term 5150, 5585. So 5150 is what the psychiatric hold term number is for adults 18 and over, and 5585 is just for under 18. and reduce risk, reduce the number of our youth that are placed on holds, even sent to the licensed psychiatric facilities. So our goal is to keep our kids in our county. There's well, let me finish this. Sorry, I went off too fast in my head. We need to reduce, overutilization of resources for our community, like law enforcement, emergency rooms, juvenile detention, AMR transport, and the emergency vehicle system. And our goal is to dispatch in person. That's the pandemic change. That's really was my goal as a program manager when I came on to this position 5 years ago. And we had increased it. We doubled our dispatch rate. I really sort of what it goes along exactly what George was saying, early intervention. And you're going to probably hear me say this a few times throughout this presentation, is early intervention, and no call is too low risk of a call. If it's the child's youth's first time having a thought, we want to talk to them. And we want them to feel safe calling us, because we're not going to come out. Our goal is not to utilize law enforcement, right? We don't necessarily go out with law enforcement. We assess for safety and we assess for that need. And if there is immediate risk, we will utilize them as needed, but we don't require them to be with us to dispatch to a home to a family we don't know. So there's also some dignity and respect in there, and privacy, and we kind of consider we definitely consider all of those things. And then another aspect of our program many people don't know is any clients that we come across that have Medi-Cal and they don't have services, we open them up. If they agree, they have to agree. And we do an assessment and a treatment plan and go into the home and provide 30 to 60 days of crisis stabilization. And then we link them to long-term services. And some of our interventions for when we're doing a crisis call, it is an in-person response or a phone. And these are just some of the techniques, like some of the things we use. We do sometimes in the moment parent coaching. If there's a conflict and the parent's calling upset and the child's yelling at them and not following their directions, and kind of coaching them through the crisis. And maybe the youth isn't suicidal, but that is still a crisis. And that still justifies calling us, so we can support through that. So it doesn't rise to the level of something worse. So those de-escalation techniques, we've been doing a lot of mindfulness and relaxation call interventions with kids directly with our calls lately. That seems to be, as I'll go into it, but that is the biggest calls right now, is panic attacks and anxiety with our youth right now, with the isolation. So it may not be that they're having suicidal ideation, but they need some support in the moment. And we're seeing them call more, and that really makes me happy, that they're reaching out on their own. It's not a doctor or their therapist or a teacher, or their parent, it's them or the parent. Those are the best. We follow up post-crisis, whether it's a call that was contained on the phone or in person. Sometimes families don't answer. That's okay, but we try a couple times and then we'll mark it blue. And then we always offer in-person safety planning post psychiatric placement or hospitalization. We try really hard to let the families know that when their child is going to be placed in the hospital, which we know is outside of our county. And I'll get to that, because we know hospitals for youth in our county. That's one of the barriers. And one of the reasons why we don't want to write holds is that we do that post-crisis in-person follow-up and support the family with really making sure safety sweeping, removing all sharps, or what was the risk that had that child or youth to be placed on a hold in the first place. We can just to help them feel more secure and safe with that. Update providers. If family comes in and they have a provider, we will update those providers. Sometimes, it may not get that information, or families will, they'll say, I don't remember my therapist's name, but we'll try really hard to help them and we get permission to update that providers as well, of course. And we do the reassessments every 24 hours. So that's part of, I'm not 100% if that's a law or just a policy of the county, but I think it's a good one anyway. Anyone that's on a hold that's sitting in the ER, they don't just sit there without any intervention, that we go in there every 24 hours and do a reassessment. And maybe something's changed within 24 hours. Maybe new family members came to support, or maybe their providers were more available to see them sooner or more often during the week, and that could keep them safe. So we might rescind a hold. And a rescind hold means we've determined the client doesn't meet criteria anymore. Therefore, the hold, we consult with the on-call psychiatrist before we make that decision. And of course, the caregivers and family and guardian, and then we rescind the hold, and the family goes home with a safety plan. And then we do the bed search. I just added one of our crisis models we work off of is Robert's. It's like a 7-step plan here. I won't go totally into it, but just so you guys have it, just really, we look at risk assessments and safety planning as really detailed. And sometimes that can be a complaint in the community about safety is, oh, they take too long, their assessments are too long, or, but really when you work with youth in crisis, it's very different from adults, in the sense that you may have several people involved in that child's life that have input and they have important information. And so you really want to make sure everybody's heard and that their input is valued and taken, and that they feel heard and part of the crisis. That could be include teacher, principals, the parents, siblings, grandparents. So sometimes it can take a little bit of a while to safety plan and really make sure a plan is in place. So this is where I like to just make sure you guys are aware of other crisis teams, which you guys probably are, especially because George does such a good job when he comes to those meetings. But there's a team in each region from behavioral wellness for the crisis teams. So they have a whole team in Santa Barbara, Lompoc, and Santa Maria, whereas we're one team for the entire county. So dispatch times might be a little bit longer sometimes, or the wait, that's why. The crisis intervention teams are those co-response teams. I don't know if some of you know about those. They started a few years ago. Before the social unrest, our county is so forward thinking and was already on this as far as kind of moving forward with new models of treatment for crisis and mental health response for our community. And so they're already up and running teams in Santa Barbara. It's with the sheriff and police department, so both areas of the police. And they have a clinician that goes out with them, and they go together. And the officer doesn't wear his uniform, he wears khakis. And so it's not as intimidating to the family. He's not there pulling his gun out on someone who's having a psychotic episode, trying to take him down. This is a much, much more family-centered response to mental health, instead of it being what we've seen before. And Santa Maria Santa Maria Police Department is developing their own crisis intervention team. They're not going to hire from behavioral wellness like the other response teams. They're hiring their own clinician, but I'm excited that I live in Santa Maria in Orchid, so I'm excited that Santa Maria is going to get one as well, and hopefully we'll be able to work with them. Sometimes we go out in tandem with the co-response team. Sometimes they respond and then they'll update us. So it just is a hit or miss. It depends on what's happening in the community, who's busy. We support each other. It's the same with all the crisis teams. We collaborate, we communicate they'll tell us when they see youth, we will tell them, hey, we wrote a hold on this youth. They're in the hospital, so they know when they go into the ER at night, this is what's there. We've done this work. So we communicate really well together, all of us. And then a couple years ago, it's on its last year, but the county was able to get a grant for youth crisis triage grant. And I put it down here instead. Sorry, guys. It's right here, should have been separated. Sorry about that. And this is a really great grant because the clinician is stationed in the ER. So right now, one person covers Lompoc and Santa Maria. And we talk to that clinician every day about if she needs help and she's slammed, or if we need help and we're slammed, we communicate and collaborate and figure out how to support families, and with the risk assessments. So Cottage is a little different because they have a whole psychiatric services that's available in Santa Barbara, and that's unique to our county because they're the only ones that have emergency psychiatric services. They have social worker, like a whole team. They have the voluntary hospitalization on site called 5 East. So some of the crisis teams don't really go into that ER because they do all the work, but they do call us to collaborate and to have us do follow up. They'll have us see a family in person if they feel that they need a safety plan but need more support. So we also communicate with them. And I forgot to mention, we're the only county in the state of California that the officers in our county do not have the privilege to write a psychiatric hold. And that has been going on for about 35 years. You might have to be able to correct me, George, but about 35 years that's been the case, and that's very unique. So the county is the one that authorizes the privilege, and they authorize these crisis teams, which is my team and the adult team, the youth triage grant clinician, and then some of the psychiatrists that are in Cottage also have that right. So they can write holds and rescind holds at Cottage too. So that reduced their need for the crisis teams to come in there as well, because they do so much of that work on their own because they have such a great team. They have a whole system there, which is really great. And then we take over on the weekends. I think the clinician's off every other Saturday, so we're just responsible for the Lompoc and Santa Maria ERs. So that I like to share about the teams, because if you were to call 911, it may not be safety that comes, because sometimes these crisis teams, now these new core response teams, might be available for a response and they might send them first. Or if they called us and we're all in the field and no one's available, that team might be the one that responds. So I like to make sure that people in the community have that information. This is just the names of the holds in case people wanted to know. There's danger to self, danger to others, and gravely disabled. And gravely disabled is an interesting hold for youth, because it has to do with someone being able to provide shelter, clothing, and food for themselves. What meets a criteria for a hold is there has to be mental health symptoms contributing to the reason why we're taking someone's civil liberties away. And with kids, a parent is responsible for shelter, food, and clothes. However, if there's mental health symptoms and someone's having some perceptual disturbances and they're feeling afraid that their parent is actually poisoning them and they're not eating, that would still meet criteria, and it's not a CWS issue. It's a mental health concern still. So these are just the different criterias, and I like to share that so you guys know what that information is, what we're working on legally have to work off of. And collateral information is always important. Parents, therapists, providers, friends, as long as they're allowed to share the information, teachers, the officers. That information is so important. Even if it's not youth and if it's adults, because we know that sometimes people aren't aware that they're having their mental health symptoms, or they're not in tune with what's happening with them, or they don't see a decline in their functioning, but others around them, their loved ones, do. So that information is really important. We actually legally, as of 2019, can write a hold on collateral. It's not done all the time, but we can if there's such discrepancies in what's happening from the presentation to what everyone else is seeing, then that might justify. So these are just things that we consider when you really look at crisis intervention and reasons to take someone's civil liberties away, or looking at what is the best clinical plan to address a mental health crisis for a youth. We look at that plan, intent, access, means, history. Future orientation is really important. Sometimes kids, they will be depressed and they will have a lot of suicidal ideation, but they're really looking forward to something that's 2 weeks from now, whether that's school related and they're really involved with their school, or if they're involved with something else, or sports. I know right now that's not usually the case because our kids aren't getting to do much right now, unfortunately, but that's important to look at, because then you can use that as part of the protective factors. So we're weighing the protective factors and the risk factors for our youth when we're making this decision. What supports they have in place, stressors, remorse. If they did ingest something with the intent to die, do they have remorse for that? Are they all of a sudden feeling like, oh wow, I didn't like to see my younger sibling so upset, I didn't like the intervention, that the medical intervention that had to happen in the ER. So they're like, I'm never doing that again. So they have a completely different disposition. That might be a reason not to write a hold too. So this goes to my next one, like, why not write a hold? Sometimes people will say, well, that this child, this person needs to be on a hold, or why did they write a hold on this one when one of my friends actually ingested and they didn't? So that's a good question. Some of the reasons, as we look at, like I said, we have no facilities and our kids are shipped out really far away. So we're looking at St. Mary's in San Francisco, Fremont, deep in LA, San Diego. We won't even look at San Diego. That's too far. Bakersfield, we have Vista Del Mar, which is one of our closest. Vista and Bakersfield are about the same distance if you look at countywide. But our kids are sent really far away. And some families don't have the resources to drive, or even participate in treatment if there's some therapy or groups around that. They may sit in the ER for 72 hours and have no mental health intervention, which can be in itself could actually increase mental health symptoms. And then I like to mention the human trafficking because, sending our youth outside, that is a huge risk these days. When you really think about that, if for some reason they were, sent out of our county and had a contact with somebody that wasn't a safe adult or something in that realm, it puts them at risk for that. And then some things to think about too is that voice and choice. One of our culture compasses is voice and choice. We really want to give families voice and choice. So if the families, giving them a chance to safety plan and really look at how they can support their loved one that's in a crisis. If we decide to safety plan and 12 hours later we're back out in a crisis and we have to write a hold, we don't look at that as a failure. That we try to look at that as actually like a success. Wow, you were able to keep yourself safe for 12 hours or 24 hours. Let's look at what you were able to do. You exhausted all measures. This is a good thing. Well, now we know you really do need that psychiatric intervention. So that's what we look at too. Also, some things I didn't put this on here, but if they have psychiatry already and are getting medications, when we send them to a hospital, the doctors will change their medications sometimes. So that could be an actual impediment to the treatment as well. Something to help prevent the hospitalization is we can go out in person post a crisis to do in-person follow-ups post-crisis. So sometimes we might have to go out each day on the weekend just to keep that youth within our county and get them back to their provider on Monday. And that's a way we try to avoid hospitalization. What happens after a hold's written? That can be really scary. Your child's shipped off somewhere and you don't have a car. That is really, really scary. So we read the advisement to the family, and then if we're at a home, we have an AMR come and take the client to the emergency room, and then they're medically cleared. They usually do blood work just to medically clear them. And now they're doing COVID tests. If they're on a hold, they'll do COVID tests. And then we will update the ER on the disposition, and we'll do that bed search and reassessment. And then we update the parents as soon as something changes or happens. And we're calling the parents the next day when we're doing the reassessment. And this is just, I like to show about our safety planning and like the details of it. I'll show an example of our safety plan. I'm having the staff write in the National Suicide Hotline because now that's considered standard of care on crisis safety plans. So we're handwriting the National Suicide Prevention hotline in there. Really digging into what are the warning signs, what are the triggers. Coping skills are interesting because it's hard in a crisis. You can't really teach somebody something new, so you got to use what they have. It could be playing with their cat. It could be sitting outside under a specific tree. That's their coping skill. Do they have access to it? How can they ask their parents to let them do that? Like those kind of things. If they lose their cell phone, we'll work with the parents. Okay, how can they ask you to call us if they need to call us? And then on our hotline, every day there's a supervisor that's a backup. So they're not out there just making these decisions. They actually are required to call the supervisor. So that is done by myself, our clinical supervisor, our director does it. She's a psychologist, which is amazing. She's amazing. And our assistant director does it. So we all communicate about these cases and work as a team around the best quality of care for these patients. And sometimes I need to consult so that, we're making sure they don't forget something, or is there something that could be of a better safety plan or a different alternative. So that's why we provide that additional support. Plus this work is hard, so there's briefing. So I talked about proactive services. So this is what I mentioned for Medi-Cal clients that are not linked. And then they may meet criteria for the Holman group, and we'll make sure they get linked to the Holman group. I know that's been a little bit of a barrier in our community in the last several months. So we might hold on to a case for a few weeks and just make sure they get that therapist.
You might mention what some people may not know, Christine, what the Holman group does.
Yes, sorry. So there's levels of mental health care, and Holman for Medi-Cal recipients is the lower level of care. So it's like adjustment disorders, maybe some mild depression, generalized anxiety disorders. But when you get to moderate to severe symptoms and functional impairments, you're going to meet criteria for Santa Barbara Behavioral Wellness Services. So that's the services that George talked about, where it's kind of like a team where they have psychiatry evaluation. They might be referred to behavioral work, where they're doing rehab work, and they're offering some groups right now. Dr. Scholl at Santa Maria he's an amazing adolescent psychiatrist. He is offering a group post-crisis, post-hospitalization now on Tuesdays at 4. We have to refer the family, but he wants to make sure he's connecting with these kids that are going to the ER. So I think he started that group all on his own, which I think is great. I hope the other areas follow, but that's going to be a great resource. We do nightly check-ins too. So if the client's already open in the clinic, they can put us on the plan. We've had a lot of referrals for that over this pandemic, when the pandemic hit. And then we take private insurance, Anthem Blue Cross, which is unique because those services I mentioned, like therapeutic behavioral service, TBS, which they go into the home 4 to 5 days a week. Then there's also wraparound, which is more of that's where they are dealing with probation and CWS children. Those services actually can be available to Anthem Blue Cross. Some insurances are starting to move in the direction to see that network therapists is not enough for some of the support, which is exactly what George is saying, right? That families need more than that. And so Anthem is stepped out of their box, and they're approving those services for families. We're hoping to contract with others, but right now we've got Anthem. And these are just some things that we do in our sessions. We definitely do continued crisis stabilization, rehab skills, coping strategies, mindfulness, DBT, communication, harm reduction, definitely supporting parents, and coaching and techniques and communication skills so they can better connect and help their child. And we're strength-based. Everything is strength-based. Every little step is an improvement, and we focus on that. Families or youth are already being hard on themselves enough with any little mistake that they make, which contributes to their mental health and getting worse. And so that's why being strength-based is so important. These are just some of the things. There's some pictures of some of the things that we do. And then we'll hand out like this 99 coping skills is really cool. We'll have them fill out what are some things you do on this sheet. Or if they're a little resistant, hey, hang on to it. When I see you next week, the therapists and the clinicians will say, mark some things you're willing to try then, and they'll kind of go from there. And then we use what kids like. Some kids are more into art, some are into music, some are into, and we use those things with our kids. This is a really popular one that seems to be what my staff are doing. This 5, 4, 3, 2, 1 mindfulness, kind of relaxation, kind of grounding technique. It kind of fits all those categories. That's why I mentioned them all. So that's a really popular one right now that they're reporting they're doing with kids on the phone right there. Changes due to COVID. So legally, we can write a psychiatric hold via telehealth now. So we have joined some school sessions with school therapists that are in sessions with youth that are concerned, and we have joined in and done assessments right there with the therapist and the youth and the parent. And I think that's been really helpful. It's also helpful if someone is actually sick, they can still get intervention and treatment right now. This has changed our field, I think. I don't think this will, just thinking about therapy and, with the shutdown and the availability now for services, some of those, some youth and people that are struggling with mental illness that can't even leave their house can actually get intervention now and some support and someone to talk to through the telehealth. And so yes, there's also the argument that our kids are isolated, but for some, this is actually, there's some positives, and we can also say that there's some negatives too. Initially, we saw a huge decrease in those calls when COVID happened. That really scared me and my team because a lot of our calls are school. So these are kids that are being seen by professionals in the school, teachers, peers, peers reporting posts that kids are making that are not that could be questionable. And we would get called out to do assessments and provide that support, get them linked, things like that. And then to go to zero was really concerning because those kids are still out there and they're still struggling. So we met with the schools, and we've seen an increase this school semester with school calls. The schools are monitoring that Google activity. So we get called by principals and school counselors if they're looking up how to die by suicide or how to kill somebody by this. We're getting called and we are responding to those calls. So that's good. And then we've seen a huge increase, we've dispatched more with law enforcement. We're getting those, as you guys heard, more of the conflict is happening in the community. So we've dispatched with law enforcement a little bit more where we're asked to go out with them. And we've seen a huge increase in calls from families, like I said, directly, which is really awesome. And then the other issue that we've seen is behavioral. A lot of behavioral increased aggression with kids. They're agitated, they're frustrated, they're not signing on to their Zoom classes. And then you've got some issues around possible, sorry, I lost my train of thought. Then you've got the panic attacks and the anxiety from the loneliness and isolation. Like it kind of goes on each side of that, that we've been seeing as some issues in what our activity has been on the calls. We have seen an increase in suicide attempts with our youth and suicide ideation from last year. And they're more around overdose and hanging. And so I don't know if to provide some education, kids are getting substances and drugs through Snapchat, and they're ordering them through Snapchat and having it delivered to their house. There is groups, we've had groups of friends where we were able to connect the dots and they all had suicide pacts. So we really assess for that and really look into that. We can't break confidentiality, of course, but we really want to make sure those kids are getting support so that doesn't happen. And then we've written about 31% of our telehealth calls have ended up in holds since the pandemic.
And that's higher than previously?
Well, that's just a number against the telehealth assessments. I would say yes, because typically our average holds against the crisis calls runs between, okay, when I first started, it was like 7%, and now it's up to 15%. So for a program whose goal is not to write a hold, we have increased writing holds. So the acuity, so what I mean by that is the severity of our youth symptoms is getting worse. The severity of their behaviors is getting worse. Things like that is what we're seeing. More kids in foster youth systems that are acting out, or there's risk of AWOL and those high risk behaviors. Those are harder to manage because AWOLing, we can't force a youth. We don't have that ability, right? To say you have to stay here and say anything. If they're going to leave, they're going to leave, right? So then we have to use law enforcement and figure out what would be the best next step for that situation. That poses some unique challenges, is what I'll say. And then we know what stigma is. And I think with youth, I have seen a huge shift. I've been in this field for 15 years. But I've seen a huge shift in the last like 4 to 5 years, where now we get kids that before it was like, oh, you're in therapy, what's wrong with you? Right? That negative stigma, the judgment, all that stuff. People think that you're crazy, but that's not the case. And now kids really are pushing each other to reach out for help and go into therapy. And oh, why don't you have somebody to talk to? I go to a therapist. So it has shifted, but there's still the stigma. And some of it is these kids are caring and worrying about their family members and they don't want to take time for themselves. Some of it is that reason. So we still have a lot of work to do around the stigma with mental health, as you guys know in your organization, but it's come a long way, I think, with our youth in this generation coming up. Especially with boys, I think there's still a huge stigma with the males asking for help, and that is a huge barrier we need to break through. Still, most of our calls are still it's about 65% female, the rest males, so 45% males. So 35, sorry, my math is off. So we still get more females that call us and reach out for support, or for females. And then I like to share that mock calls are really important. You guys can call us if you're concerned. First of all, you can call us if you are worried about anybody, and we can help get you in the right direction. Second of all, if you do have somebody that you're concerned about, helping them to make a call just to say, oh, just to see what they'll ask you. That helps that barrier and that stigma and the worries. Also, just to joke around, kids don't really talk on the phone these days. They are not raised by answering a phone. So I always joke, my own 17-year-old acts like when I say order your own pizza, he's like, oh my God, no. I'm like, oh my God. So he will act like I've asked him to do something terrible. So this is like a generational shift. Our kids don't talk on the phone. It's hard for them. They'd rather do chatting and the messaging, which I have resources at the bottom of my PowerPoint where there are those available. But this is unique because they can, if you do a mock call, they can hear that the person's kind and wants to hear what they have to say on the other phone and isn't judgmental, and we're not going to come out ablazing with law enforcement to take them away. That's not the point of calling us. So I always really want to encourage those and people to reach out for that support. And then when you call, just the demographic, I think just asking for help and requesting is part of what we do. Is we really help the community and our callers and our consumers know how to ask for that help. Like, even if it's their insurance, say we don't take their insurance, it's getting here, this is what you need to say when you call that number. Why don't you write this down, or can I send this to you so you have the language, so that they will make sure to understand your child needs support. So that's part of it. But then, name, date of birth, if you have it, what is the crisis? And then we're always going to assess for safety first. Is there medical attention that needs to happen? If someone's standing there with a knife, we are not going to take that knife from somebody. We're not a first responder, so we're going to help you call 911. Or we may call for you if you can't, or we'll have you call. And then the decision of what the officer decides to do on scene, they may not call us. They may make a different decision for themselves for the situation. Like I said, all calls are good calls. There's no early intervention is the best intervention, is what I say, for suicide prevention, homicide prevention. That has been a little bit of an uptake. We've seen that for the past couple of years. I mean, it's interesting, you think about the era of school shootings, and then COVID happened, and of course we're not in school. But that aggression and homicidal ideation is still an issue. And sometimes kids will say, I've had these thoughts for years and I've just tried to manage it, and they didn't know what to do or ask for help. So they were struggling with mental health issues around that, and they needed some intervention. So hopefully we can, even with homicidal thoughts, that is still a great place to have early intervention. Here's a list of some of the warning signs. New ones on that new research has come out is burdensomeness. Kids will actually express burdensomeness a lot in ours. What we find when we go out and work with youth, they're really concerned about their parents who might be working two jobs, or they're really concerned about their siblings who can't get on their Zooms and they have to take care of their siblings. They're worried about everybody else, and they don't want to put the burden on and one more thing on their family, whatever their family's dealing with. So a lot of times that is a huge risk factor, and we do assess for that. And hopelessness. Hopelessness was discovered a few years ago. Now some newer research is coming out about shame. I don't know if you guys have heard that, and Brene Brown is in shame around contributing to mental health symptoms and making that worse. So we'll see what comes out of that for, as far as some new research, but that's something to look at, is about shame, and how that affects things. But this is the whole list for warning signs just to look for. And then I like to talk about what if you are concerned about someone who has thoughts of wanting to die. What do you do? Whether they're an adult or a kid. I think it's the same intervention for both. You listen. You sit and give them that time. Don't be afraid to ask the question and be direct. Are you thinking of killing yourself? Are you thinking of harming somebody else? Are you thinking of killing somebody else? If that's the topic that they discuss with you. Have you harmed yourself? And if you're afraid of those if that's a hard question to ask, then get them to somebody that can ask them that. So that's calling some hotlines, or going to another safe adult or a safe friend. And then following up. If it's a situation where they seem okay, people that struggle with mental health look like they're okay all the time. So really just make sure that they know and understand that if you can be that person to check in with them, then check in. With kids, there's no option. We have to keep our kids safe. That is a non-questionable, non-negotiable. But if just in general, if you have somebody you're concerned about, these are some of the things to think about. And then I'll just go through these really quickly and I'll leave it for questions. 2019 numbers just came out. I have them right here. The actual number of suicides went down. I couldn't find this pretty graph here. It's still the second leading cause of death, but I am really, really excited to see those numbers come down for the first time in 10 years, because that means that all the legislation and the programs and all the work that like NAMI does and behavioral wellness and getting the word out is working and helping people reach out for help. And that is amazing. Like, that just fills my heart, that number has come down for our United States. And I was going to mention the CDC is a really great website. You can go in there and look at any data. It's very cool because you can look at every state and the suicide and homicide rates, and of course all the medical reasons for death. But if you're talking about this topic, they break it down by ethnicity and race. It's really awesome. And then I just like to share the myths of suicide. Suicidal teens overreact to life events. Yes, that can be true. And yes, we have teens have normal shifting in emotions, right? They have normal drama with friends all the time, right? Like things that come up. However, you still want to look at, okay, that's still a crisis to that teen. So whether it's a breakup, whether it's a friend that's upset with them, or they got a bad grade, or they didn't make it on the team, we know they're resilient and they're going to be okay, right? We feel that in our hearts, but they don't feel that and don't know that. And so we've got to be the ones to listen, validate them, Ask them how they're feeling. What can you do to support them? And if you can't be that person, like I said, then get them to somebody that can. So overreact is not, they're not necessarily overreacting. It's that this is their experience. And if this becomes their experience over and over and over, that changes their brain, and that can affect their actual physical health as well. It affects their learning and their ability to concentrate and become functional adults. So they're not overreacting. Talking to teens about suicide makes them likely to kill themselves. No, it does not. It does not. Talking to teens about suicide as any subject, whether it be about sex or about drugs, it gives them the opportunity to share their thoughts about it, or ask questions, or feel safe to come to you as an adult, whether you're the parent or an aunt or a sister or a caregiver or a friend, being that safe adult. Now, kids might not always have the best ideas, and they don't have the brain development to sometimes make the best decisions. But if they can share what those thought processes are, reflective listening and just listening doesn't mean we're agreeing with them. Then if we listen to them, they're going to be more likely to be open to some suggestions we have for them, which might be the more rational decisions, right? Or some suggestions that are more healthy for them. And then suicide happens without warning. This is also a myth. There's usually a sign, or there's some sort of person they may have talked to, or letters. Sometimes there is, there are people that say, I had no idea that this youth was struggling. So it's just about being able to see the warning signs. And then I like to show these. Positive self-talk wheel is really great for kids, and like you can even make it on like a paper plate and spin it and like talk and like utilize that with them if you notice some negative self-talk coming out. And then the circle of self-care. Those of us that work in mental health, this is really important too. That those of us that have family members that have mental health, it's so important to take care of yourselves so that you can be that support for your family that is struggling. And then, yeah, this is just the point where I talk about resources. These are just some of the cultural compasses, the values that we try to utilize when we are assessing families. But the crisis text line is great. That's when your kid's going to text at 2 a.m. And they have an algorithm. They have this amazing system. They explain it all so easy on their website. Anybody can go look at how they function. It's awesome. And then the National Suicide Prevention Hotline. And then for the LGBTQ population, the Trevor Project also has a hotline, a chat online, and a text. And then there's the Trans Lifeline for transgender population. We give all these resources out to our families. And then these are just other resources that we use. The American Association of Suicidology has some great interventions and tools and research, the CDC, and then we have a local American Foundation for Suicide Prevention. There's a walk every September, although this last September that didn't happen. They work with the Santa Barbara Response Network, and so they're local and they do amazing work in Santa Barbara. And then, as Rachel wanted me to show, the YouthWell has a resource directory, and it's youthwell.org, and sorry about that. You can it's alphabetical, and it shows you all the resources in Santa Barbara County that might be relating to the needs of your family and what the agencies do. And yeah, and I'm always open. I want feedback. If you feel like something didn't go right on a response, I have new staff. Maybe it got missed in training. I want the feedback. I want to collaborate. I want to get this resource out. So feel free to call. We don't look at it as you're bugging us. We want to make sure that our people are satisfied with our program. So we consider it a collaboration, not complaints, and we have room to grow. So that's it. Okay, I'll stop sharing. So then I'll answer any questions.
Alrighty, so well, where do you start? Huh? We do have a couple questions in the queue, which I'll turn over to Tom in a minute. But before I do, I just want to say that, I mean, even those of us that are fairly, know the system fairly well, I really had no idea that there were so many tools in your toolbox. And the other thing that struck me, Christina, was that a lot of these, a lot of the things that you mentioned that can be helpful in a crisis situation for kids, these are skills that we teach families in our family to family class. You were talking about reflective listening and how to listen without judgment and encourage conversation. These are all skills that we work on with families. So as you and your staff proceed, we're always happy to have families referred to the family to family class. And you know, in the beginning when we first started doing it, it was you know, it was seen as just for families of adults. But what we're finding now is that we've tried to progressively take people with like you know, adolescent kids that had issues and so on. And what we're finding is that a lot of the there's a lot of crossover. A lot of what we teach in family to family really is relevant, especially for parents of teenagers. You know, that where we sort of avoided that. You know, when family to family first came along. So anyway, just an aside. So Tom, we got a couple questions, I know, and then I will ask anybody else that hasn't put a question in, put it in the chat box, or when we're done, you can raise your hand and we'll go around and make sure everybody gets their questions answered.
So we'll just go in order here. I think you see the questions too, Christina, in the chat box, but I'll just read them out loud. And the first one is, are the schools incorporating mental health coping strategies in the Zoom classes? And if so, at which age group?
That's a good question. I think it's different for every school district. And so Santa Barbara City itself has a huge array of services for youth in their schools compared to the rest of the county. They have AHA, and someone asked a question about that and I will share. But AHA, they have hospice, they have a family service agency that provides therapy, CADA, which does substance abuse and does groups. Oh gosh, who am I missing? There's so many.
There's also the Mental Wellness Center does the Mental Health Matters classes for sixth graders.
Mental health first aid, yeah.
Yeah, they do the mental health first aid for youth. And I had it on my list and I meant to mention it. And of course I still didn't mention it on my list. All the different trainings that you can do for that. So it depends on the school district. Many of the school districts contract out with the community-based organization agencies, which is like that's what Casa Pacifica is. So that's an example, or CALM. CALM is also in the schools in Santa Barbara. That's another one. And they contract out to do certain therapeutic services. So whether they're implementing them in the classrooms, there's curriculum like Tom mentioned, or was it George, that is going in the health classes. Like AHA is a curriculum that's part of those classes. AHA is a, am I mixing up AHA with, I just went blank on AHA. No, AHA that's the right one. She's gonna present to my team at our all staff, and they focus on healthy relationships, and they do trainings on healthy relationships, like when is it starting to be abusive, what's physical abuse, mental abuse, you know, sexual abuse. They go through the pressuring and teach the kids about boundaries in relationships. That they have that's an amazing curriculum they do in certain classrooms. I just don't know which ones. So it depends on the school.
I was more wondering if it was, this is Frank, by the way, I was wondering if it was more on, like, since the pandemic started, right? So schools had to shift into a Zoom process. And then what we noticed with our kids, we got a sophomore and a senior in high school. And so at the beginning, it was all about, okay, let's keep going, right? Classes, we got a rigorous thing, we got to keep it going. And then at some point, I noticed, at least in our district, there was a recognition, like, okay, this isn't working. We're losing kids. Kids are getting depressed. This is, you know, weighing on them. And so then I know for our schools, it seems like now the teachers are incorporating a lot of their class time and sort of putting the book aside and then just spending time with the kids talking about how you feeling? This is really tough. And so I've really appreciated that, but that's just been more recent. And I was curious about if if that's happening to a larger extent. And then that's high school level. But I'm also hearing just
Right.
from in my work at work with the employees that we have a lot of young families. I think you talked about the older siblings that are stressed because they're having to help their 7 8 year old sibling because mom and dad are working. All those things are sort of like bubbling up, and you're seeing this explosion of kids really not coping. And then we're seeing it in the workplace where
Mhm.
employees are having to take time off because their kid, and they're distraught. Their parents that are going, I don't know what to do. I can't be here at work. My kids are broken. And so I was just hoping that, you know, what your presentation was wonderful. I'd love to see. It's one thing to have these things taught in a classroom and have an in-service every now and then prior to COVID, but now in this time, it's like we need it like right now, yesterday, and at a younger age too.
Yeah, no, I'm glad that you're experiencing some of that shift. I have a senior as well, and I have not seen that shift with his school. And but with the schools we are responding to, we've seen a decrease in the elementary school responses. Now that you're bringing this up, Frank, we have responded to 5 6 7 year olds, and where it's mental health. It's not because they heard somebody say something, right? Or things like that. Those we haven't, that's interesting. That age group we haven't seen as much recently, but I'm not aware if the teachers started incorporating in the elementary schools. I know that we contract with some of the schools to do therapy. Like one of my staff does therapy at Guadalupe School but those kids have IEPs. Those are called individual education plans for those that might not know. So those are kids that are identified that have they call them emotional disturbance. I never really liked that term with the school. And then they have a learning disability on top of that. So they are required by law to provide certain services. So I know my staff that are doing those interventions with the kids, but I don't know about specific classroom teachers doing things. And I think it depends on the teachers too, right? Some teachers are just more skilled in those things, and some are really focused on the teaching, I think. And then, like you said, there's teachers that have kids that also have to be in Zoom, and then they have to teach. This is such an interesting and unique time in our lives as a whole world. We've thought about it, and some of us therapists have gotten together and said, all of us are literally going through the same things that our families are going through that we're treating. And when does that ever happen? When does that ever happen where we're juggling getting our kids into Zoom, and what do we do with work and the stress and worried about all, it's very interesting time for everybody right now. I just wanted to mention that. That's why self-care is so important. But right now, I think a lot of the community is experiencing sort of a PTSD like experience, like a wartime, because certain people are really concerned about their health and they're really worried, and you go outside and, oh my gosh, my mask, and oh, did I get exposed? And that constant exposure to that worry is really not good for our health, and we're all experiencing it right now. But I think that's a good point, Frank, that you brought up. Some schools have started incorporating, I know before the pandemic, curriculum like relaxation time or like mindfulness, and like with those younger groups, and they're labeling it or doing feeling identification and teaching them how to even identify their own feelings. But not every school district does things the same. So,
So the next question, Christina, is I've been in a crisis situation with a 9-year-old when SAFTY wanted police dispatched before coming, but police took up to 90 minutes to respond. How can we improve response?
oh wow. I'm sorry about that. Yes, so sometimes I have seen when there's a behavioral issue going on or whatever it is, when it's a younger child, the officers will see that as that if something else happened in the community, that is more important. Or if sometimes they could be even en route to a crisis, and they get a call for something that is much in criminal activity that they have to respond to, like an armed robbery or something that horrible was happening to somebody else. We've heard that we've experienced that. We've experienced also where they said, sorry, we don't have anybody available. We can't go out to this home that the kid has a knife and is destroying their house. We can't. We'll call you when we can come out. And we're out there dealing with that crisis. So how to improve it? I think that just the communication and the collaborating, and if you did have a response or a situation that didn't go as well, I think calling the supervisor and really collaborating about that and seeing what could be done different, or maybe it was a training issue on my staff. They are, if it's a safety issue, they will say to call police. If there's a kid that's throwing things and breaking things, we can't put hands on a child, and we're not trained to do that. So we would want someone else that could come in as a presence in that manner, that could help contain the situation in that way so that we could do some intervention.
So
I don't think that answers your question though.
Christina, this is Terry, and I'm the person who asked the question. And I unfortunately have had this experience more than once. So it was not isolated.
Mhm.
And being home alone with a child that is really violent and destroying things, and not being able to get any kind of response in any kind of timely fashion is super scary and super frustrating. And, you know, I'm being told not to lay hands on the child either.
Mhm.
But honestly, what I ended up doing on 2 occasions was tackling her and sitting on her just to try to de-escalate the destruction that was going on. The police have responded to me in ways such as, well, this sounds like a parenting issue. And, you know, other sort of very condescending, patronizing things, not recognizing that a 9-year-old can have a serious breakdown as well as an adult, and can be maybe even more so out of control because they don't have a maturity level to be able to respond to their own emotions in any way. So, I mean, I don't know. I don't know what goes on behind the scenes, but if there is some way of communicating to our law enforcement too, that, you know, this is serious stuff. And I don't take it lightly if I have to call someone for assistance. It's a last resort. And to be in that situation where your team, I understand, they don't want to come out if it's an unsafe scene, but not to be able to get somebody from law enforcement there either. I mean, what do you do?
So
Right. Okay.
can I just step in for a minute, Christina? Because you reminded me of something that one thing that NAMI's doing, and Terry, we can talk more about it offline because it might be something you'd be interested in. But some of you are familiar, and I think Christina mentioned crisis intervention training that we have in our county now for the police. We're doing 4 of these academies a year, I think, where we put through about 40 officers from any law enforcement officer from any agency in the county is eligible. It's run by the sheriff's department. But anyway, it's a 40-hour treatment, and it focuses quite a, you know, almost not exclusively, but largely on de-escalation skills around mental health crises. And it's, you know, mostly for adults, because that's mostly where the kind of crises are there. But here's what I'm saying. We are invited to come in and to present for 2 hours of those 40 hours from the perspective of a family member or a person who themselves is living with a mental health disorder that has had an interchange with law enforcement in the past. And, you know, it's not just people that have had problems either. We have some people that have had good experiences, and so we know we don't want to be seen as just the bad guys. But when we have a situation like you just described, it's not okay. And this is one way that we can bring it to the attention of of the people that are going to be responding to these calls. Maybe not the very person that you responded to your call, but the point is that over time, we hope to get just about all the law enforcement officers in the county trained in these techniques. And every time we go in and do one of these classes, we get the comment back from the participants that it was one of the most important parts of the 40 hours that they got. So, that's one thing that we can that we're trying to do to address situations like this, because that's just not the way cops are trained, and we have to kind of retrain them, and
Right.
That's what we're doing.
Well, George, thank you for that. Part of what has been my problem is not necessarily the officers themselves. When they have arrived, they've been really great at de-escalating and gathering information from me, and then safety has teamed up, and it's been an overall good experience. It's getting past dispatch, and it's generally dispatch that has been the most disrespectful to me, I think, or impossible to help to get them to comprehend how bad the scene here is.
Well, we do have dispatch that participates in the CIT training too. All the dispatchers eventually, I think, go through that training too. So it's not just law enforcement, but that's good to know, because it's good to know, number one, that we're seeing the results of it in the calls that our officers are making, but that we still need to focus on the dispatch.
Terry, can I ask you a question? Do you live in the county area, or do you live in?
I'm within the city of Santa Barbara.
Okay, so your 911 call goes to the city dispatch.
Yes.
And I'm wondering, George, you might know if any of the city dispatchers have been through that training.
They have historically, but I don't know whether all of them have or not.
I know the county ones have.
Yeah, I do know that City of Santa Barbara is just now implementing a crisis co-response team, like Christina was mentioning. And so, I don't know whether they're going to be responding to calls for children and adolescents as well or not. But, as they're just now gearing up, I think last report we had, they had only worked like 10 or 12 shifts. But where we have implemented those teams, they've been tremendously successful in the county in getting better outcomes to crisis calls. So,
and Christina, can I ask you a question along the same lines? So, are you do people call your office directly, or are you always called through dispatch?
No, we have a hotline. So that's what I was going to suggest to Terry. So really quick, I want to address. So Terry, I just want to say thank you for sharing your experience. I know that can be really hard, and I want to make it better for you if you are dealing with a crisis again. So I have a suggestion that if you are treated like that, to bypass even dispatch if it's in our working hours, and I can alert my team to you. So you could if you use the language, I'm having a hard time with dispatch. Can you help me with 911, or can you guys dispatch? And that way we can, because if we call dispatch, not to disempower you, but that might help a little bit, and it will take away that stigma. That doesn't negate that needs to be worked on, but I want you to feel that there's some support, and on my side with my program, working with my team, maybe we need to look at, could we stay outside and wait for law enforcement, and maybe having that parent come outside and making sure that the youth is safe and we can provide some intervention until we can't put hands on a child. But I'm willing to definitely look at, you brought up some really good points that it's caused me to rethink about some of the processes.
Christina, you probably aren't going to want to hear this, but I have I have called your team directly more than once, and at one point when could not get I could not get help from whoever was on the other end of the phone at SAFTY when I was literally begging them to call law enforcement for me because I knew the response would be better, and was told that you didn't do that and you weren't going to do that.
That's not true. So then that's when I want to know those things.
And sure. I know that SAFTY had called law enforcement for me previous to that. Yeah. And so breakdown. Yeah.
No, definitely. And I have some staff that have left. I'm not blaming staff. I'm just saying we should be doing that if that's the course. Now, eventually we do, if we have a family that's calling us to call law enforcement all the time, we have to look at the clinical issues around that. If that's what articulating and saying, you know, I've called law enforcement and they tell me that this is a behavioral issue and I'm a bad parent. Can you please assist me with this? That's going to trigger my staff to realize, oh, okay, then that's not that this family, we're disempowering this family to call out for the resources that helping them learn how to do that. So I think there's a balance with that. And I will definitely talk to my team about that too. So I apologize if you felt like you didn't have a good response a few times.
Well, sure. I understand that. And, you know, there's also a time frame of trying to get the right services in place and medications and everything else. And during that time frame, for me, for this family, it was a lot of calls to get assistance. But it's been radio silence for several months now because we have found a combination of medication and therapists and things that are working for now. But it's just when I need help in the future, and I'm suspecting that we may go there again, or when some other family is needing help, you know, for several days or even weeks until things get balanced out. You don't want to get to the point where someone's telling you, you know, why don't you just give the kid a spanking and move on or whatever. You know, it's not that.
Definitely.
Thank you. So we could have a couple more questions, though, right?
Yeah.
I want to make sure everybody gets their questions answered. I don't want to move on too fast. But
the next question is similar to that first one, which is our teachers, school districts in our county asking for training on this topic to increase awareness.
I asked that question. It was you incorporated the answer. So yeah.
Okay. And then the last one I have here is, can you talk about AHA?
Yeah, so AHA is that relationship curriculum. It was started by Christy Stillwell, and they do curriculum for healthy relationships in the high schools. It's only in Santa Barbara City. I'm trying to get her to come and bring it throughout the county for our high schools and junior highs. We have definitely dispatched to kids where they want to die because of a breakup. That is what's triggering their suicide ideation, and they're very depressed about those sort of relational issues, or there's situations where relationships aren't so healthy and there's really poor boundaries between the kids, and someone wants you to give all of your passwords to all your social media, and they're all of a sudden now controlling that youth. So they go and teach about that, and they have parent support groups on how to help parents manage and monitor those situations. They have a website. It's I was just on it today. AHA.org, I think it is. But also that Youth Well registry, you can see what's great. It has the emblem of all the programs, so you can see, and it gives you a description too, which I think that's a really great resource that they developed.
So was that the last question, Tom, that we had?
That's it.
Unless somebody has some other ones, I'm going to use the chair's prerogative and ask the last question. So Christina, I can't remember, it seems to me that at some point we talked about the possibility of creating at least a few beds in the county. I mean, a county of 400,000 people, we don't have a single bed for, and we're sending people to Bakersfield and Los Angeles and all these places. Where was that? Is there anything underway that you're aware of, or are we looking at anything? Is the department looking at anything?
I have not heard anything. There's a hospital in Marion. We built a new hospital in Marion and Santa Maria, and there's the old hospital sitting there, and they use it. I think they use a little bit of it for certain things, but the talk was that they were going to turn that into a facility, a locked stabilization unit. And then I always ask for beds for youth, and then they say, well, maybe eventually. And so some of the barriers that I've heard is that the licensing to have minors is very rigorous, and it's not even about the financial piece of it. I guess there's just so much more I don't even understand that goes into being able to have minors. So Dr. Kettler has said he's open to that and wants to push for that. So we'll see. I have no idea where they're at with that. Dr. Kettler didn't come to our last meeting. I noticed, which he never misses a CAT meeting. I have no idea. I'd rather have a locked facility, a crisis stabilization unit. It's a 23-hour and locked, because then the youth would stay in there, whereas unlocked, they could just come and go. I did forget to mention Noah's Anchorage is also another good resource in Santa Barbara. It's used to help homeless youth, but it's also there they do crisis intervention. They have therapists. They have a whole myriad of programs, but we use it as a respite for the clients where sometimes suicide is contingent. If my parents don't give me my video games back, I'm going to kill myself. Okay, well, that doesn't meet criteria. Where's the mental health symptoms, right? So, but there's still conflict, or the parent and the youth are arguing and engaging in power struggles, and they just need some separation and respite. Sometimes we've used Noah's Anchorage for that, and then the parents, Noah's Anchorage does a great job. They do assessment, and they'll develop that plan and crisis stabilization for moving forward once the youth is there. But the difference when it's unlocked, and because it's such lower level, they have to agree to go. So the youth has to agree to go, and the parents have to agree to go. And the second the youth says, I don't want to be here, they can't keep them there. So that's where we need a locked crisis stabilization unit.
We believe the same thing for adults. We have the same issues because what's the point of a crisis stabilization unit if people can walk away and
Right.
a cop drops you off there, and 15 minutes later you get a call again. Anyway, so really appreciate it, Christina, and I hope that we can share this with a much larger audience, because we recorded it and we'll make it available to the rest of our membership. But thank you so much for a really enlightening conversation.
No, thank you so much. But I realized I misrepresented AHA. That what is love is what I'm talking about. What is love is about. AHA does teach educators in schools in Santa Barbara about emotional intelligence. I apologize.
Emotional intelligence, okay.
Because this is recorded. I made a mistake. I mixed the two groups up. Either way.
That's the problem with recording.
Oh no, either way, both those groups are amazing, and I wish they could come throughout the county. But thank you so much for having me. You guys were an awesome group, and please feel free to reach out to me or ask me any questions. And I like the feedback about the program or your experience or anything, and I'll do any trainings. If you guys want risk assessment trainings, we do those more extensively than what I mentioned, of course. So feel free to reach out, and thank you so much.
Appreciate it.
Thank you.
All right, everybody. We'll see you next month
Thank
when
you.
the topic is substance abuse treatment for people with mental health disorders. And the speaker's Alice Leghorn. So, all righty.
Thanks again.
Thank you, everybody.
Okay.
Bye-bye.
Bye.
Bye.